Last class, I discussed with you the hyperlipidemia. Abnormally, that means it is a abnormally high level of any or all lipids, all lipoprotein in the bloods. And I also discussed about that hyperlipidemia is a major modifiable risk factors for cardiovascular diseases, atherosclerosis, including the coronary heart disease. Primary hyperlipidemias are genetically based, but there are lots of secondary causes, especially diabetes mellitus, thyroid disease, renal disorders, liver disease, alcohol consumption, estrogen administrations, and drug associated changes in the lipid metabolisms. You can see just only you collect a blood in the test tubes and wait for minutes, you see the level of lipids, how much. You can easily, grossly you can assess, and you can also see in the pictures that blocked lumen, a branch of left coronary artery, there is a infarctions, there is an infarct. And how it occurs, you already know what is infarctions and how it occurs. In the previous class, it is discussed. Today, mainly I want to discuss about the familial hypercholesterolemia. It is a genetic disorder characterized by high cholesterol level, especially very high level of LDL in the bloods. Previously you know in the last class, LDL means bad cholesterols. So their high level are less responsive in case of familial hypercholesterolemia. These high levels are less responsive to the cholesterol control method that usually effective in peoples. Many peoples have mutation in the Ldlr genes that encodes for LDL receptor protein, which this normal LDL receptor protein which normally removes LDL from the circulations. So, what are the genetic defects? If the genetic defect is homozygous, that is having two abnormal copies, may cause severe cardiovascular disease even in the children. People who have one abnormal copies, that means the heterozygous forms of LDR gene may develop cardiovascular disease prematurely, that means less than 40 years. High level of cholesterol normally do not cause any symptoms, but yellow deposits of cholesterol-rich fats may be seen in the various places on the body, such as around the eyelids, outer margin of the iris, tendons of the hands and elbow, knees, particularly the tendons of Achilles. If you see the picture, the yellow patches consisting of the cholesterol deposits above the eyelids in familial hypercholesterolemia. This marked by arrow. Again, the familial hypercholesterolemia, we can classify the 5 major classes of Ldlr mutations. Class 1, the Ldlr is not synthesized at all. Class 2, it is synthesized but not transported from the endoplasmic reticulum to the Golgi apparatus for expression on the surface. Class 3, not properly bind to the LDL on the surface receptor. Class 4, LDL bound to the LDL receptor but does not cluster with the receptor mediated endocytosis. And class 5, LDL is not recycled back to the surface. So, these are genetically we can classify the familial hypercholesterolemia. Next, we can discuss the ischemic heart disease. It is a acute or chronic form of cardiac disability arising from the imbalance between the myocardial supply and demand for the oxygenated blood. Ischemic heart disease can present as angina pectoris, myocardial infarctions, chronic ischemic heart disease and sudden cardiac death. So, if we want to discuss about the pathogenesis of ischemic heart disease, again the coronary atherosclerosis accounts for more than 90% of the cases, and superadded changes in coronary atherosclerosis, but non-atherosclerotic cause are vasospasm, stenosis of the coronary artery, arteritis, thrombotic disease, embolism, aneurysm, compressions and trauma. Whatever may be the cause, we recognized mostly, that is more than 90% cause is the coronary atherosclerosis. So, we must know the atherosclerosis. So, angina pectoris, what is angina pectoris? Is a paroxysmal and recurrent attack of precordial chest discomfort. Why? It is caused by transient myocardial ischemia. What type of transient? 15 seconds to 15 minutes, and that is insufficient to induce myocyte necrosis. So, there will be no infarctions. The pain is likely to be a consequence of ischemia induced release of adenosine, bradykinin and other molecules. And angina pectoris, it is a reversible cell injury. Usually we found three patterns: stable angina, prismatal angina and unstable angina. Stable angina is a typical form, most common and caused by imbalance in coronary perfusion relative to myocardial demand. And thanks to God, it is relieved by rest. So, angina pectoris typical form, it is relieved by rest. So, another you remember, it lasts for 15 seconds to 15 minutes myocardial ischemia. So, not sufficient to cause the necrosis of the myocardium. The prismatal variants and unstable variants also. Unstable variant, it may prolong more than 20 minutes or occurring, even it may occurs at rest, caused by disruption of atherosclerotic plaque or vasospasms. It also can be treated. And most important to our class today is myocardial infarctions. If you fails to diagnosis the myocardial infarctions, you may lose the patients. So, you must recognize the myocardial infarctions immediately, and you should steps for treatments. So, death of myocardium, myocardiac muscles due to prolonged severe ischemia, and here it occurs the irreversible cell injury. What type of injury? It occurs at necrosis. What type of necrosis? Is a coagulation necrosis. You already know the necrosis have two basic types. One is the coagulation necrosis, another is a liquefactive necrosis. Coagulation necrosis occurs in the solid organs. So, most important examples of coagulation necrosis is a myocardial infarctions. Another important is occurs in the kidney, but the liquefactive necrosis is mostly it occurs in the brain, and another common is abscess. So, now I am to discuss the incidence and risk factors of myocardial infarctions. Myocardial infarction may occur virtually at any age, but less than 40 it occurs nearly 10% or less, but 45% occurs more than 60 years of age. Myocardial infarction frequently and progressively increases with increasing age. Incidence of myocardial infarction strongly correlates with the genetic and behavioral predisposition to atherosclerosis. So, if any persons have a atherosclerosis, he is more prone to develop the myocardial infarctions. So, black and whites are equally affected. Middle-aged male people have increased risk of myocardial infarctions, and more women are generally protected against myocardial infarctions regarding the reproductive age. Why? Due to estrogen productions. But myocardial infarctions is also common of death in older women when there is a estrogen production is declines. If you see the picture, the site of myocardial stenosis were occlusions. It mostly occurs in the left anterior artery, we called it LAD, more than 50%, and the right coronary artery is about 30 to 40%, and left circumflex artery is about 15 to 20%. What happened in acute myocardial infarction? Why occurs? The location, severity and rate of development of coronary obstruction due to atherosclerosis and thrombosis depends. The size of vascular bed perfused by the obstructed vessels, duration of occlusions, metabolic and oxygen demand of the myocardium, the extent of collateral vessel formations, the presence, site and severity of the coronary arterial spasm, and other factors such as heart rates, cardiac rhythm, blood oxygenations. All these factors are responsible or depends on myocardial infarctions. So, first morphologically we want to discuss or we want to recognize the pattern of infarctions. One pattern is transmural infections, another is subendocardial and multifocal microinfarctions. Transmural infarction necrosis involve nearly full thickness of the ventricular wall and occurs due to occlusion of the large vessels of the coronary arteries. Subendocardial infarction necrosis is limited to the inner third or most one half of the ventricular wall. Multifocal infarctions seen where there is a pathology involving only the small intramural vessels. This may occur in microembolizations, vasculitis and vascular spasm. So, diagnosis depends on the clinical symptoms, ECG changes, ST segment elevations and laboratory diagnosis. In laboratory diagnosis, rise of cardiac markers, particularly the troponin I and troponin T, very efficient markers and earliest marker which rises or which rise in the blood. So, if the clinical symptom is seen then immediately you do the cardiac marker, especially the troponin I and troponin T, then you can diagnose the patient very efficiently. Though the ECG changes appears a bit slow. So, clinical symptoms in myocardial infarction is the prolonged cardiac pain in the chest, epigastrium or back. Pain may be crushing, stabbing or squeezing in nature. It also you will see that profuse sweatings in myocardial infarction, anxiety for fear for impending death, nausea and vomiting, breathlessness, even the patients may go in collapse or syncope. So, if you see the cardiac markers in the charts, biochemical markers, we can see the troponin I abnormal activity detected 3 to 8 hours both in troponin I and troponin T. At the same time, CKMB also appears 3 to 8 hours. And peak value of abnormality in troponin I 24 to 48 hours. And troponin T is 70 to 100 hours peak value, and CKMB is 10 to 24 hours peak value. Others are the LDH and AST and myoglobin can also be assessed in the diagnosis of myocardial infarction. So, our main important is troponin I and CKMB. Why? Earliest marker appears in the blood and it lasts for 24 hours to 48 hours peak value. So, what are the complications of myocardial infarctions? Arrhythmia, congestive heart failure, cardiogenic shock, mural thrombosis and thromboembolisms. It may cause the rupture, cardiac aneurysm, even the pericarditis. So, today I will finish up to this, and next class I will discuss about the rheumatic fever and I will complete the cardiovascular systems. So, in the next class you prepared for the rheumatic fevers, and thank you to you all.